This module is titled Chest Trauma and Thoracic Injuries. The learning objectives for this module include: compare the clinical manifestations of a pneumothorax, fractured ribs, and flail chest, describe the purpose, methods, and nursing responsibilities related to chest tubes, explain the types of chest surgery and the appropriate preoperative and postoperative care.
Chest trauma contributes to 75% of all traumatic deaths. It can be either blunt or penetrating in nature.
Blunt trauma occurs when the chest strikes or is struck by another object. A common cause of blunt trauma would be a motor vehicle accident. So you can see how trauma would occur if the chest hits the steering wheel, or when you're in an accident and your chest moves forward. The shoulder harness that keeps you in place can also cause blunt trauma. Oftentimes the external injuries appear minor, but the internal injuries may be severe. Compression of the chest can also occur, and this can happen from a contusion, a crush injury, or an organ rupture. Penetrating trauma is an open wound in which a foreign body impales or passes through the body tissue. Examples can include knife wounds, gunshots, any type of injury to the chest with a sharp object.
A pneumothorax occurs when air enters the pleural cavity. Normally, negative pressure exists between the pleura, which surrounds the lung, and the parietal pleura, which is the lining of the thoracic cavity. This pressure allows the lung to be filled when the chest wall expands. This pleural space only contains a few milliliters of lubricating fluid, and this allows there to be decreased friction as the lung tissues move. When air enters this space, it causes a change in that pressure, which then causes the lung to either partially or completely collapse. A pneumothorax can be spontaneous, but it can also be caused by open or closed trauma. There are different types of pneumothoraxes. A spontaneous pneumothorax typically occurs when there is a rupture of the small blebs located at the apex of the lungs. These blebs can occur in young healthy individuals, and then you would refer to that as a primary spontaneous pneumothorax. Or they can be a result of lung diseases such as COPD, asthma, cystic fibrosis, or pneumonia. That would be considered a secondary spontaneous pneumothorax. Risk factors for a pneumothorax include history of smoking, because it increases bleb formation. Other risk factors can include being tall, thin, male gender, having a family history of pneumothorax, and having a previous pneumothorax. Another type of pneumothorax is iatrogenic pneumothorax, and that typically occurs from some type of procedure. So during the procedure, the lung is punctured and it results in a pneumothorax. A common procedure where pneumothorax is a risk factor is really anything, any type of thoracic procedure, but the one I can think of most common would be pacemaker insertion, central line insertion, things like that.
A pneumothorax is air in the pleural space. When there is air in the pleural space, there is partial or complete collapse of the lung. As the volume of air trapped in the pleural space increases, the lung volume decreases. So this condition can be suspected after blunt trauma to the chest wall. A pneumothorax can be closed or open. You can also have a tension pneumothorax, a hemothorax, or a cryothorax. For a closed pneumothorax, there's no external wound. This can happen spontaneously, but there is air in the pleural space. With an open pneumothorax, air enters the pleural space through an opening in the chest wall, so that may happen from that penetrating chest wound, such as a gunshot or a stabbing. A tension pneumothorax is rapid accumulation of air in the pleural space and can cause high intrapleural pressures. A hemothorax is an accumulation of blood in the pleural space from an intercostal blood vessel, internal mammary artery, the lung, the heart, or other large blood vessels. It can occur with or without a pneumothorax. A chylothorax occurs when lymphatic tissue fills the pleural space. This is most oftentimes seen when there is trauma to the lymphatic system or when there is a malignancy. A pneumothorax can be small or large. Someone with a small pneumo may have mild tachycardia and mild dyspnea. As the pneumothorax gets larger, the person will have increased respiratory distress. They may represent with shallow, rapid respirations, dyspnea, air hunger. They may have decreased O2 saturations. They may have chest pain and absence of breath sounds in the area of the pneumothorax. A chest X-ray will show the presence of air or fluid in the pleural space and a reduction in lung volume. A tension pneumothorax is a medical emergency and typically affects both the respiratory and the cardiovascular system. If the pneumothorax is not relieved, it is likely that the patient will die from severe hypoxemia and inadequate cardiac output. In a situation with a tension pneumothorax, a physician or someone trained would insert a large bore needle into the anterior chest. A chest tube would then be inserted and connected to water-sealed drainage. A flail chest results from the fracture of 2 or more ribs in 2 or more separate locations, causing an unstable segment of the chest wall. During inspiration, the affected portion is sucked in, and during expiration, it bulges out. So this periodic movement prevents adequate ventilation of the lung in the injured area, increasing the work of breathing, which eventually results in hypoxemia. Clinical manifestations of flail chest include rapid, shallow breaths, tachycardia. The thorax is asymmetrical and uncoordinated with respirations. To diagnose flail chest, a chest X-ray will be needed. ABGs can also identify if the patient is having hypoxemia or if they are in respiratory acidosis or alkalosis. The treatment would be airway management, oxygen. The patient may need IV fluids and will also need to control the pain. Some patients may need to be on mechanical ventilation. Eventually the rib fractures will heal and the flail chest will be resolved. The insertion of a chest tube can take place in the emergency department, at the patient's bedside, or in an operating room. The purpose of the chest tube is to remove air and fluid from the pleural space and allow the lung to re-expand. You can see by these images where the chest tube is inserted and where the pleural space is. A patient may have one chest tube, they may have 2 chest tubes, and the placement of the chest tube typically is determined depending on whether or not they're trying to remove air or fluid from the pleural space. A Heimlich chest drain is typically a small drain that is used for uncomplicated pneumothoraxes where there's little or no drainage and no need to be hooked up to suction. Typically these are patients who will be managing at home, so it can be concealed underneath their clothing and can have easy maintenance at home. A patient who has a chest tube in the hospital setting will typically be connected to a drainage system shown in the images here. The basic compartments will be described. The first compartment is the collection chamber, and this receives fluid and air from the pleural space. Fluid stays in this chamber while the air vents to the second compartment. The second compartment is the water seal chamber, and this contains 2 centimeters of water, which acts as a one-way valve. As air enters from the collection chamber, it bubbles through the water. The water prevents the backflow of air into the patient from the system. During normal use, there may be intermittent bubbling in that water chamber during exhalation, coughing, or sneezing. There also may be normal fluctuation, which is called titling, and that reflects the interpleural pressure during inspiration and expiration. The third chamber is the suction control chamber, and this applies suction to the chest drainage system. The water suction control chamber uses a column of water with a top end vented to the atmosphere. This chamber is typically filled with 20 centimeters of water. You can also have what's called dry suction, and this is where suction is connected to wall suction, and you will use the regulator control dial. Typically there'll be a physician's order to indicate what your suction should be programmed at. There are a couple of things to keep in mind when caring for a patient with a chest tube. You always want to monitor for bubbling in the water seal chamber. There should not be any bubbling, except like when I said, with coughing, sneezing, or exhalation. There will be titling with respirations. It is important to ensure that all connections are secured with tape. This will help prevent air leaks. You want to assess for kinks, leaks, or fluid-filled loops. The drainage container must remain upright at all times and below the chest. During transport, and when the drainage chamber is at the bedside, there are hooks on the back of the chamber that allow you to hook the drainage container to the patient's bed frame to ensure that the drainage device does not get tipped over. Throughout your shift, you will be observing volume, shade, color, and consistency, and you would record the output and your findings appropriately. Typically, adults have their suction set at 15 to 20 centimeters of water, but again, this may vary with your physician's order. The chest tube site should be assessed and cleaned with the dressing changed every 24 hours, except we do not change the dressing on the day of insertion. The chest tube should never be clamped. You do not clamp the chest tube during transportation. The only time you would clamp a chest tube would be with a physician's order. Nursing assessments for a patient with a chest tube would include assessing their respirations, their lung sounds. You'd be assessing for crepitus, which means you would palpate around the chest tube insertion site, seeing if you have any of that subcutaneous emphysema, which is subcutaneous air. It could indicate a leak at the insertion site. You're assessing vital signs, assessing output into the chest tube drainage chamber. Every day a patient with a chest tube should have a chest x-ray, and you're monitoring that the pneumothorax is improving. And also you can expect that a patient with a chest tube will have some pain, so you want to be assessing and treating pain appropriately. For a patient with a chest tube, we would want to encourage them to change positions frequently. That will help promote drainage from the chest cavity. We would recommend a high or semi-Fowler's position to promote lung expansion. Coughing and deep breathing, teaching incentive spirometry is also extremely important for these patients. We want to ambulate as soon as possible, treat their pain, and we have to remember that if this chest tube comes out, this can be a medical emergency. So it's important, if you have a patient with a chest tube, to make sure that at their bedside they have petroleum jelly gauze, another gauze, paper, and pressure tape. So in the event that the chest tube would come out, you can put the gauze, the petroleum gauze, the gauze, and a pressure dressing over that insertion site. There are a variety of different types of thoracic surgeries that a patient can have. A lobectomy would be removal of one lobe of the lung. Oftentimes that's done on patients with lung cancer, tuberculosis, lung tumors, or other fungal type infections. A pneumonectomy is removal of the entire lung, and most often that's done for lung cancer. Wedge resection is removal of a small localized lesion that is usually only a small portion of the lung, so that can be done for biopsies or for small nodules. A thoracotomy can be done for removal of the lung or surgery on the lung or for surgery on other organs. So typically there's an incision into the thorax. A segmental resection is removal of one or more lung segments, and again this is typically done for patients who have lung cancer. Preparing our patient for a thoracic surgery would be the same as preparing any patient for any surgical procedure. We would assess any diagnostic tests that they had done prior to the surgery and notify the surgeon of any abnormal findings. We would do a complete head-to-toe assessment, but we want to make sure we do a good focused lung assessment that would include percussion and auscultation. Teaching would include coughing and deep breathing, the use of incentive spirometry. We'd want them to know about how we're going to manage their pain postoperatively. We could teach them some chest splinting, so they can splint their chest during that coughing and deep breathing. They can also splint their chest with any movement in bed, when they get up to ambulate, when they change positions. We want them to know that they may have a chest tube, so we'd want to give them the information about the purpose of the chest tube and any concerns about activity or restrictions with the chest tube. And we just want to make sure that we address any of their concerns, talk to them about how they're feeling about the surgery, and make sure their questions are answered. Our post-op care for a patient with a thoracotomy will be the same as it is for all post-op patients, but we'll remember that they may have a painful post-op incision as well as a chest tube site, and we would also have the care and the assessment of the chest tube.